Dear colleagues, this is a zonular cataract. Let us watch the surgical steps. This is the main incision, 2.8 millimeter. The patient is young, about 30 years old. Now, in this case, I want to stain the capsule with Trypan blue dye. This is one side port on the left side of the main incision. And now, this is air bubble. This is air through the side port. Now I'm going to inject Trypan blue dye through the side port to stain the anterior capsule of this cataractous lens. Now the dye is washed out. Friends, this is an unedited video and you are going to watch each and every step of the surgery. The duration of surgery is about 9 minutes. And now this is viscoelastic substance, HPMC. In this case, I have made one side port and this is another side port on the right side of the main incision. In this case, I want to do the Rhexis and I want to take this zonular cataract as a guide for the Rhexis. We sometimes use Rhexis marker. Here the cataract itself is the Rhexis marker. I'm just going along the margin of this zonular cataract and doing a round Rhexis. Excellent. So this is comparable to femtorhexis. And now I'm going to do hydrodissection just to tilt this cataract so that I can use my lens tilt technique. This cataract is very soft. Only one particular zone is having opacity. The rest of the lens is almost clear. Now I have injected viscoelastic substance behind the cataract and in front of the cataract, and now is the time to enter into the eye with the Phaco handpiece. I am going to use Oatly Cataracts 3 Phaco machine. No financial interest. This is the easy tip of Oatly's Phaco machine. And now see how I am removing this cataract. Just aspirating and applying a little bit of power. The bevel was sideways. Now towards the end the bevel is up so that I don't catch the posterior capsule. And now cortical lens matter is to be removed. Little bit of HPMC is injected into the anterior chamber, and now I am going to use a 23 gauge Simcoe cannula for removal of these cortical lens matter. This is a very simple instrument and this instrument works very well in my hands. I also use bimanual irrigation aspiration, but since this instrument saves my time, I use this instrument. That's it. The cortical lens matter is cleaned. Only a little bit of lens matter is there at 1:30 o'clock. Here it is removed. Now in such cases, when the patient is young, even if I polish the posterior capsule, I tell the patient during counseling that the patient will need YAG laser capsulotomy 3 months after cataract surgery. Some patients need even earlier YAG laser capsulotomy. Sometimes I do YAG laser capsulotomy after 1 month. Now viscoelastic substance is injected. In this case, I have selected a hydrophobic aspheric intraocular lens from Abbott Medical Optics. This is Techniques 1. No financial interest again. The lens is loaded in the lumen of the cartridge. The lens is advanced. And now it is placed on the injector, and the piston moves the lens forward towards the tip of the cartridge. Now I am going to enlarge the incision just by a little bit, 0.2 millimeter, to make the incision 3 millimeter. It allows easy delivery of the intraocular lens. However, I can implant the lens without increasing the incision if the cartridge has a narrower tip. That's it. The lens has been placed in the capsular bag. Now viscoelastic substance is thoroughly cleaned out. I clean it in several steps. This is step 1, just by flushing with BSS. We flush the anterior chamber, remove most of the viscoelastic substance from the anterior chamber, and now I go behind the IOL and flush the capsular bag. If we use sodium hyaluronate, it saves time because it takes less time to remove sodium hyaluronate. And now I use the irrigating probe of bimanual IA to flash out some more viscoelastic substance. I go behind the intraocular lens again and flush the capsular bag. That's it. The lens, the periphery of the lens is nicely overlapped by the capsule all around. The lens is nicely centered, so this is ideal placement of the intraocular lens. Little bit of moxifloxacin has been injected into the anterior chamber, and now the side ports are being hydrated. That's it. So the side ports are hydrated, and I take another look with higher magnification and remove the viscoelastic substance that sticks to the corneal endothelium. That's it. Hope this video will help you in developing your skills. This is how I form the antechamber and conclude the case. Thank you for your attention.